Comer, thank you very much for calling the hearing and for your great leadership on this issue. Thanks to the witnesses for coming, and I want to thank the members on my side of the aisle who've arrived already, and Mr. Auchincloss from Massachusetts, who joins us today, who's an expert in the field. It's the second time we've come together to talk about this issue that affects everybody in America, access to affordable medication. And here's the bottom line value that we're seeking. In the wealthiest nation on earth, at the wealthiest time in our history, everybody should be able to afford the medical care and attention and prescription drugs that they need. In 2021, we spent $4.3 trillion on health care in our country, nearly twice as much per capita as the next closest country. Most of our healthcare system is for-profit, with many big corporations involved making billions of dollars in profits annually. During a multi-year investigation conducted by committee Democrats, we found that some major pharmaceuticals employed profit-maximizing pricing practices at the direct expense of the people who rely on their medications to survive. Today, we're investigating the role of pharmacy benefit managers, PBMs, which are supposed to negotiate lower drug costs and improve the delivery of medication to patients. That's the theory. What we've actually heard is that certain PBM business practices may be favoring more expensive drugs and making it more difficult for patients to get timely and affordable access to the medication prescribed by their doctors at the pharmacy of their choice. At our last hearing, we heard from witnesses who suggested that PBMs and other big health companies are using their enormous market power to maximize their profits at the expense of patients and community pharmacies. As of today, 3 companies control 80% of the PBM market. The same parent companies that own these PBMs also own health insurers and pharmacies, so the parent company can profit at multiple points of access through the healthcare system. PBMs profit from rebates and fees from pharmaceuticals that want PBMs to include their drugs on insurance plans. PBMs also profit from health insurers directly, which reimburse PBMs when medications are dispensed to patients at the pharmacy. Because of the integrated market, PBM parent companies can also profit from directing patients towards the retail and specialty pharmacies that they own. In the question of PBM profits versus patients, we need to make sure that patients are coming out on top every single time. The first step is understanding the problem. The committee's drug pricing investigation shone a light on the way that drug companies have spent years exploiting patients. In the Inflation Reduction Act, Democrats worked to lower drug costs for seniors by allowing Medicare to negotiate prices directly with manufacturers, capping out-of-pocket costs for patients covered by Medicare and limiting the price, for example, of insulin to $35 per vial for seniors. Today, we've got an opportunity to build on that success. This hearing will help us understand the ways that PBMs add value and improve patients' experience, as well as the ways they may not be living up to the hype and contributing to our crisis of drug affordability and accessibility. Given their central role, we need more transparency into how PBMs operate and how their practices might be working alongside others in the supply chain, including Big Pharma, to increase the price of drugs that we all pay. I hope together we can build upon our drug pricing reduction work so far and move towards the moral North Star here, which is that every person in America should be able to access the affordable medication they need in order to survive and thrive with their families. Thank you very much, Mr. Chairman. I yield back.